Hello, my name is Elise Banu, and this is my Community Nutrition Intervention Program proposal. So first we will discuss the nutrition-related health issue, which is type 2 diabetes. Type 2 diabetes is currently the 7th leading cause of death in the United States. There are approximately 30.3 million Americans with diabetes. It's more commonly found in middle age and older adults. However, in recent studies and research, it has been observed in children and adolescents as well. The overwhelming majority of individuals with diabetes has type 2. So about 90 to 95% of cases that you look at, people have type 2 diabetes as opposed to type 1. Research points to type 2 diabetes being heavily lifestyle oriented, meaning the risk factors associated with type 2 diabetes relate to altering one's lifestyle. And we focus mainly on lifestyle and behavioral changes. We make that the focal point for prevention. So now that we've reviewed the nutrition-related health issue, we're going to view the target population, which is Hispanic women ages 45 and older in the United States. So although type 2 diabetes affects multiple races and ethnicities in the United States, Hispanics are in fact disproportionately affected by type 2 diabetes. Type 2 diabetes is highly prevalent among Hispanics and is the 5th leading cause of death among the Hispanic population. And Hispanic individuals are 50% more likely to die from type 2 diabetes than their white counterparts. And if you look at the picture here, you look at who's at risk. You're looking at people who are 45 years and older, people who are physically inactive, people who have a family history of type 2 diabetes, high blood pressure, a history of gestational diabetes, and are overweight. And at the bottom, it mentions that African Americans, Hispanic, Latino Americans, American Indians, Alaskan Natives, and other minorities in the U.S. are highly at risk for type 2 diabetes. So to further view this target population, we have to look at the proportions of both males and females. So diabetes rates are actually expected to increase in women by 220% as compared to 174% in men. And research shows that those who are 45 years of age or older are more likely to be diagnosed with type 2 diabetes. So upon viewing all of this research on the target population, my target population of focus will be Hispanic women ages 45 and older in the United States. So now we're going to view the determinants of the target population and health issue. So first we're going to look at community infrastructure, which includes physical factors that include but are not limited to the safety of neighborhoods, proper transportation, and the availability of healthy food. So our target population is looking at all of these determinants. So you're going to look at lack of construction of sidewalks, and living in rural areas may not have proper bus transport, or transport may be infrequent to the point where people cannot make it to work and school. And we also look at the safety of neighborhoods, which means, people really are not comfortable leaving their home. When viewing determinants, we're also going to look at economic stability. So there's a high correlation found between those with low socioeconomic status and health outcomes, which when we're looking at this target population, the Hispanic population has a high prevalence of individuals who are of low socioeconomic status. So economic stability is very important to look at. We also look at education level, which is a social determinant that has been found to be linked with improved health outcomes. So in other words, the more education someone has, the more improved health outcomes they will have. We also look at lack of access to proper medical care, which means limited access to healthcare and medical insurance can actually lead to fewer preventive interventions, limiting the screening for complications. So, in our target population's case, regular screening does not always occur for type 2 diabetes. And finally, we also look at culture and community support, which means that these determinants are very important for an individual and community to stick to preventive measures if they have that sense of culture and support. So now we're going to look at the behavioral and lifestyle factors of the target population. We're going to be viewing lack of exercise and consuming an unhealthy diet. Those are the two main behavioral and lifestyle factors of the target population that highly increase the risk for type 2 diabetes. Weight loss and increased physical activity have been shown to help prevent or delay the development of type 2 diabetes and those high at risk for the disease. And exercise can lead to improved glycemic control. So now we're going to look at the intervention program objectives. For my process objective, multiple pamphlets and brochures will be mailed to neighborhoods and health clinics that are predominantly Hispanic during the first 3 weeks upon program initiation in order for Hispanic women to learn about prevention strategies and lifestyle changes regarding type 2 diabetes. My learning objective is during weeks 4 to 6 of the program, 25% of Hispanic women ages 45 and up will demonstrate knowledge regarding type 2 diabetes prevention and lifestyle modifications via surveys, which will be administered through mail, email, and even health clinics. For the behavioral objective, during months 2 to 3 of the program, 30% of Hispanic women ages 45 and older will report healthier eating patterns after participating in nutritional cooking courses in order to prevent type 2 diabetes through the administrations of surveys through mail, email, and health clinics. And finally, the outcome objective is upon the 6th month of the program, 40% of Hispanic women ages 45 and older will report weight loss, adoption of healthy eating patterns, and significant knowledge of how to prevent type 2 diabetes via survey distribution through mail, email, and health clinics. So the model I have selected for my intervention program is the health belief model. And I chose this model because it is a psychological model that attempts to predict and explain health behaviors by focusing on the attitudes and beliefs of the individuals. It seeks to discover why exactly people will not seek preventive measures and also finds a solution for these individuals so that they may overcome barriers and adopt new behaviors. It is appropriate for many different types of interventions, including those that are health promoting and those that focus on health risk behaviors. And finally, the intervention will especially be focusing on health risk behaviors as type 2 diabetes revolves around lifestyle changes such as diet and exercise. And here is a picture of the health belief model. We're going to be looking at the constructs of this model, which include perceived susceptibility, perceived benefits, perceived barriers, self-efficacy, cues to action, and perceived severity. So now we're going to apply the health belief model to the program intervention. And the first construct, perceived susceptibility, refers to how susceptible someone believes they are to getting a certain condition, in this case, type 2 diabetes. So we're going to mail out informative brochures to all Hispanic households in the United States that are low income within the first 3 weeks of the program. The material on the brochures would include information regarding the statistics of Hispanics, specifically Hispanic women who are at risk for developing type 2 diabetes, and these statistics would reveal how susceptible they are to developing the disease, therefore changing their perspective of susceptibility. And this information on the brochures would, of course, be gathered from reputable sources such as the CDC, the World Health Organization, and the US Census Bureau. So the second construct is perceived severity, which is how severe an individual believes a condition or disease actually is. So in those same brochures that I mentioned before in the previous slide, the consequences of type 2 diabetes would also be mentioned within these brochures, such as skin complications, neuropathy, foot complications, kidney disease, etc. And this information would be included in these same brochures that will include the statistical information as well regarding type 2 diabetes. So now we're moving on to perceived benefits, which refers to the benefits that someone gains from adopting the new behavioral change. So this can be accomplished in two different ways in the intervention program. The informational brochures that were mentioned in the previous slides will include material regarding improved quality of life when women begin to exercise regularly and consume healthy meals in order to work towards preventing type 2 diabetes. The cooking and diet courses will be offered at all schools in neighborhoods of low socioeconomic status in order to educate minorities specifically. So these classes would include Hispanic mothers of the surrounding households and will be welcome to bring their children and family as well. And the classes would educate the participants on how to cook with less sugar, fat, and sodium, as well as provide a cooking demo for the participants. And following the class, recipes would be delivered to all participants at the end with a flyer or a brochure. So now we also have to view the perceived barriers, which are the obstacles that someone may encounter when trying to engage in behavior change. So limited access to healthy foods, lack of education regarding where to buy these healthy foods, and the lack of exercise information and education are all perceived barriers within this specific target population. So in order to overcome this, the cooking courses are classes that are set in a convenient location. So local schools would be the best area to set these cooking courses. They would educate Hispanic women and their families on what types of foods to purchase as well as where to buy them. And at the end of every class, flyers will be handed out to participants with a recipe and where to purchase healthy foods in the area. So now we're going to look at cues to action, which are stimuli that can create awareness within a community. And this involves the informational brochures mentioned before, which are distributed to health clinics in neighborhoods that are predominantly Hispanics and specifically women's clinics. And flyers around the neighborhoods will also be posted in order to produce awareness within these communities and give more cues to action to the community. So now we're going to look at self-efficacy, which refers to how capable an individual believes he or she is in adopting behavior change. So with this, the biggest thing is to instill confidence. So all informational brochures and educational cooking courses must be conducted with a motivational and encouraging manner. Follow-up communication will also occur at the end of every class, as well as a question and answer portion for participants. So the teaching courses will also be sure to communicate and perform a walk-around at the end of every class in order to be available for any questions the participants may have. And this would just further instill the confidence in all participants at the cooking courses. For the intervention program, we're also going to view the budget and timeline. This will be a nationwide type 2 diabetes prevention program for Hispanic women ages 45 and older in the United States. There are approximately 13.6 million Hispanic women ages 45 and older in the United States. The CDC estimates that a type 2 diabetes prevention program costs $500 per person annually. My program will be implemented for a total of 6 months. So instead of it being $500 per person annually, it will actually be $250 per person annually. It will consist of mailing informational brochures for low-income neighborhood Hispanic residents. It will include cooking and educational courses offered 2 times a month, which will be offered at local schools within the Hispanic neighborhoods. And these courses will be 1-hour-long courses that will be held by a registered dietitian or by an individual who works for a local type 2 diabetes nonprofit organization who is also knowledgeable of type 2 diabetes diets. The total cost of this program would be roughly $2 to $3.4 billion. Again, this is based off the Centers for Disease Control and Prevention, and it's based off the CDC estimates for a nationwide prevention program. Per person, this breaks down to $250 with a total of 6 months. This breaks down to about $41.67 per month per participant, which further breaks down to $20 per month for the cooking courses, $20 per month for the employees teaching the courses, and the extra $1.67 for brochures and flyers. And finally, we're going to view the evaluation design, which for my evaluation design, I have selected the impact design because it measures the total worth and effectiveness of a program. It also assesses the efficiency of the program and whether or not it had an impact on the community. Grant seekers will want to evaluate how much the participants actually learned about the subject, so how much participants learned about type 2 diabetes prevention methods. And we would conduct a small-scale experimental study on a sample population. And a good sample population to use would be Bexar County, since Bexar County is heavily populated with Hispanics, and we could further break that down into Hispanic women ages 45 and older. We are going to view the logic model, which involves the situation, inputs, activities, outputs, and outcomes. For the situation, we know that type 2 diabetes is a significant problem in the United States, and we also know that the Hispanic population is at high risk for developing type 2 diabetes, and $245 billion annually is spent on type 2 diabetes alone. When viewing inputs, we have staff, time, location, which in this case involves schools and neighborhoods and health clinics, fundraising, and planning. And the fundraising involves getting the funds we actually need to run this program. So although $2 to $3.4 billion seems like a lot of money, and it is, we are reaching out to not only the American government, but we're also reaching out to local nonprofits, charities, and local businesses in order to help put this program together. When we look at activities, we are educating Hispanic women as well as their families. The cooking and diet education courses are another activity that we're providing. And follow-up individual communication post meetings is another thing that we offer. When viewing outputs, we have our educational brochures, flyers, diet education, and type 2 diabetes prevention education. When viewing outcomes, we have our initial outcomes, our intermediate outcomes, and our long-term outcomes. Initial outcomes are that Hispanic women 45 years and older will demonstrate knowledge regarding type 2 diabetes prevention strategies, and Hispanic women 45 years and older will demonstrate knowledge of consuming a healthier diet to prevent type 2 diabetes. Our intermediate outcomes are Hispanic women ages 45 and older will report healthier eating habits within the first 3 months of the program, and Hispanic women ages 45 and older will report shopping for more fruits and vegetables after 3 months of the program initiation. And again, these will be measured for the evaluation portion of the program via distribution of surveys. And finally, we look at our long-term outcomes, which are after the nationwide 6-month program is complete, statistics will show a 20% decrease in pre-diabetic Hispanic women ages 45 and older. And after the nationwide 6-month program is complete, reduced economic costs will be observed regarding type 2 diabetes. At the bottom, we see the assumptions, which in this case, assuming that the intervention is successful, reduced rates of Hispanic women ages 45 and older will be observed at least within 1 year after the program intervention. We do not assume that all Hispanic women ages 45 and older will be present for the dietary courses. However, the program has been sure to provide locations that are convenient for participants to gain optimal participation rates. And finally, we view the external factors. So attendance is a factor to consider within this particular program intervention. Not all women will be able to attend. However, the locations will be made as convenient as possible. So schools within the neighborhoods are a convenient location for women to go to these courses. And another external factor to consider for the intervention is that participants may not follow through with the learned material following the program intervention.